I'm Professor Jonathan Barratt. I'm a Professor of Renal Medicine at the University of Leicester in the UK and a consultant nephrologist in the John Walls Renal Unit. I've had a career-long interest in IgA nephropathy, studying basic pathological mechanisms in the laboratory and bringing those understandings into the clinic in early phase and late phase clinical trials. So very much involved in this revolution of new therapies for IgA nephropathy, and I'm involved in the international guidelines with KDIGO on how to approach the management of patients with IgA nephropathy. So IgA nephropathy is what's called a glomerular disease. So it's a disease that affects every single glomerulus in both kidneys, and we have around 1 million glomeruli in each kidney. And it has a relentlessly progressive course, with the protein IgA and these complexes of proteins being deposited in all the glomeruli, triggering inflammation and scarring, and ultimately loss of kidney function. And normally it manifests in its early stages by the presence of blood and protein in the urine, but over time there is loss of kidney function. As we lose those functioning nephrons, they scar and stop working. It's a disease that commonly we identify for the first time in young adults, so people in their 20s and 30s. It's likely, however, that they've had the disease for quite some time, they just didn't know about it. And the real challenge with this disease is it very rarely causes symptoms at the beginning, and so patients don't really know they have this kidney disease unless they, for some reason, have a blood test to look at their kidney function, have their urine dipped looking for blood and protein, or they have their blood pressure measured. And normally in my practice, that's what triggers a referral to a nephrologist. Is a doctor realizes there's something the matter with the patient, even though they don't know it themselves, and they refer to myself to go through the process of making a diagnosis. So typically we make a diagnosis with a kidney biopsy, and then what traditionally has happened is patients are given general treatments to control blood pressure. They're given advice about lifestyle modification, so to reduce the salt in the diet, stop smoking, exercise regularly, be an ideal weight. And then we've really had very little to offer patients up until the last 2 or 3 years. We've controlled their blood pressure with drugs like renin-angiotensin system inhibitors. And what we've desperately needed are treatments to actually target the fundamental problem in IgA nephropathy, which is the formation of these immune complexes. And in the United States, you're fortunate enough to now have 4 treatments approved for the treatment of IgA nephropathy, another one coming at the end of this month, and probably another one coming the first half of next year, and probably another 2 every year for the next few years. And the rest of the world is slowly catching up. So we do have new treatments that have been shown to be safe and effective and deal with both the IgA nephropathy from an immunological perspective, as well as a general protection of those remaining nephrons. So the goal in IgA nephropathy is to stop the formation of those circulating immune complexes, stop them depositing in the glomeruli, and protect the kidneys against damage. And we know that the abnormal IgA is produced by plasma cells. And mezagitamab is a drug that specifically targets plasma cells through their cell surface expression of the protein CD38. So mezagitamab is a CD38 depleting antibody. And what the study has shown that I presented at the ASN is that if you specifically target these cells with mezagitamab, you can reduce the pathogenic IgA in the circulation. That translates to less blood in the urine, less protein in the urine, and most startling of all, no loss of kidney function over 96 weeks in a group of patients that are high risk of losing their kidney function over that time period. So mezagitamab is given as a subcutaneous injection. It's given over repeated courses in the first 22 weeks of the trial, and then treatment is stopped. And what's really startling about the data is that if we go out 60 weeks, we go out over a year off treatment, those initial changes that we see in terms of resolution of hematuria, reduction in proteinuria, stabilization of kidney function are persistent. So even off treatment for over a year, we're still seeing the drug have a positive effect. And what's even more interesting is that this drug specifically suppresses those pathogenic forms of IgA that form these immune complexes. Even when normal IgA has recovered, there seems to be a persistence of its effect on those pathogenic cells that we believe are ultimately driving this disease and driving loss of kidney function. First and foremost is this was a safe treatment. The study was designed to look at safety, and really the safety profile was excellent. And in particular, what we think about if we're suppressing the immune system are the frequency of infections, particularly severe infections and unusual infections, and we didn't see that with this trial. We saw clear evidence that this treatment was improving the health of the kidneys, and we saw that by the fact that we saw less blood in the urine, less hematuria in these patients. We saw significantly lower levels of proteinuria that were sustained over the course of the trial. We saw reductions in the pathogenic form of IgA, and collectively what this translated to was stability in kidney function. And just to give you some context, similar patients in other trials, given standard supportive care, would typically lose around 10 to 12 mils of GFR over a 2-year period. That's usually around 10 to 20% of their kidney function. In this study, the patients lost no kidney function. So 0 kidney function loss over a 2-year period compared to a loss of kidney function of around 10 to 12 mils of GFR. So really startling effects. These data have supported the initiation of a global phase 3 clinical trial called OMEGA that is looking at exactly the same regime of mezagitamab in patients with IgA nephropathy at high risk of progression. It's currently recruiting, and the goal of this treatment is to demonstrate the safety of mezagitamab, but also its efficacy so that we can take these data to the regulators and have mezagitamab approved for the treatment of IgA nephropathy. And that trial is going to look at a change in proteinuria at 9 months as a sign of early efficacy, and then look at the protection of GFR over a full 2-year period. So if we replicate the results from this early phase study, it will truly change the way we think about treating IgA, particularly the fact that we could maintain that treatment effect for so long off treatment.